Good afternoon, everyone. Thank you for the invitation, Madurai's team of ESTN. My task is cut out as not very broad as Dr. Arun's talk, but I'm going to just give you a broad overview following up on Dr. Sriram's discussion about insulin usage. The points is we all know type 2 diabetes is a progressive disease. As we move along, if people do not follow the lifestyle change, we address them or advise them, then it is going to progress. If they lose weight initially, then things are going to change. But our common garden variety patient continues to progress with the same weight, so we have to give them drugs. And most of the time, the drugs continue to increase, and we need to have an ideal strategy about drugs and as well as insulin for our type 2 patients. I'm primarily going to focus on type 2 here and how do we address this continuity of care. So 40 years back, we had one or two drugs, glibenclamide, metformin. We have got more choices now. And after that comes the GLP-1RA, and then we have now got this wide number of insulins as well with choice. No doubt regarding insulins or drugs, they have made our lives better, they have made our patients' lives better. But the appropriateness of therapy determines the outcomes. So if you're a type 1 diabetes, it's life-saving. If you're a type 2, it's relative insulin deficiency and insulin resistance. So your drugs have to be strategized on top of diet, exercise, and other lifestyle changes as well. We can avoid complications just by controlling our sugars properly and by just controlling to wherever 1 to 2% better HbA1cs, we can reduce heart failure, renal replacement therapy, blindness, and amputations. And just a 1% reduction will give you all these. I'm not going to elaborate on this due to time, but it will reduce your complication risk, whether macrovascular or microvascular complications, by 20 to 40%. And this is what I meant when the natural history, your insulin resistance reaches a peak and stays there, but your insulin secretion drops down as you go along. And this line is where you're diagnosed with type 2 diabetes. So already you've lost a significant amount of beta cell function. Your ticking clock for your heart disease is starting somewhere 5 years prior, and then your microvascular complication starts there. And eventually, people need multiple medications, as I said, and move on to insulin. Our priority for today is just where we run out of medications here, our oral combination therapy, and how to address this for our patients in a better way. And we are all aware that there is a large clinical inertia with both from our patient's perspective as well as the doctor's perspective. And most of us wait for the HbA1c to go and then increase our drugs rather than proactively increase our treatments. And this is a widespread phenomenon, whether it's India, US, or the UK, it's the same. So moving on, when do we consider insulin as a therapy in a patient with type 2 diabetes? When a combination therapy of 1, 2, 3 drugs are not working on our patients anymore, when some of our medications are inappropriate or adversely affecting our patients, when they do develop hepatic or liver failure, special conditions like high-dose steroid usage, infection, surgery, or pregnancy, these are the times when we use insulin, and in a hospitalized patient as well, and somebody who has got severe hyperglycemia not responding to conventional therapies. And broadly speaking, we address this as 3 areas, where initial management, where the patient presents with symptomatic hyperglycemia, where we want to address the symptomatic hyperglycemia with insulin. The common garden variety is 10 to 15 years down the line, we would like to give insulin when the drugs are not responding. And then they reach a chronic complication stage where there is end organ damage and you want to address insulin rather than drugs at that time. So insulin as a treatment is bound by lots of complications, and initially it's bound by an inertia from the patient's side. The patients are really, really scared that they're going to take a medicine, an injectable medicine for long term, which is going to be lifelong. The fear of hyperglycemia and weight gain forms a big challenge in our patients. And there is a bigger fear in our patients' mind saying that most insulin therapies in their thinking processes attached to some fear or an old history. If you recall, most of our patients would say, my uncle had insulin, he died after 5 years. My uncle had insulin, and 2 weeks later his leg was amputated, or associated with end-stage renal failure. So these are bad experiences which have accumulated in their mind, which is the cause most of the time for their bad inertia. Then there is this associated psychological processes of self-blame because they've not done their homework properly. They tend to avoid injections as a therapy. And then concerns, as I said earlier, of risk of hypoglycemia, weight gain, and complexity of regimens, and the efficacy of treatment as well, with the social media apparently giving a lot of advice. Physicians are worried about their patients. They have a fear whether when you offer it to your patients, whether they will refuse. They are worried about how the monitoring will happen at home, whether the patient would address hypoglycemia in the correct way possible. They are already worried about the patient's cognitive abilities, and also whether the patient will comply with the treatment correctly. So these are the ways where the concerns are addressed. And I'm not going to dwell on this, but we have got lots and lots of insulin. I don't need to tell this audience that we have got most of our insulins available today are human insulins, and generally we use human insulins manufactured by recombinant DNA technology. And if you have a choice, analog insulins are more physiological and compliant with our meal plans. So we started with short-acting insulin as rapid-acting insulin and long-acting insulin as NPH. And we have moved on to our analogs, which are color-coded as this. And again, the amino acid sequences in this insulin change the half-life pattern and the way they behave. Two things bear in mind when you address insulin therapy. We still have this problem of 40 IU and 100 IU. Most injectables or pen fills have got 100 IU per mil strength, whereas your vials are mostly available as 40 IU, but there are 100 IU vials as well. So if you need to be aware when you prescribe your insulin which strength you're addressing, and the correct syringe if they are using a vial to use this. And this is very, very important. Otherwise, you would be giving the wrong dose to the patient. So for a 40 IU syringe, it's a 40 IU vial, it should be a 40 IU syringe. For a 100 IU vial, it should be a 100 IU syringe. So this is color-coded as orange and black, respectively. And the activity profiles of these insulin, for the blue line is a regular insulin, which is human act rapid, generally, and the NPH is our conventional long-acting insulin, which works anywhere between 12 to 16 hours. And we've now got short-acting analogs, long-acting analogs as basal insulin, and then there are intermediate acting, which is our conventional NPH, and we have now got long-acting analogs for which work 1 to 3 days, and we are expecting basal insulin, which can work up to a week's time. And by this, the number of availabilities, we are able to produce a physiological replication of what happens in our systems by adapting to meal patterns. But whether our regimens will work like this inside is a challenge. And using pens can also help have our patients better adapt with insulin, because it encourages people with multi-dose insulin therapy. It adds convenience and enhances portability, which means you just carry the pen with you wherever you go. They offer flexibility of dosage and reduces insulin wastage as well. And it also offers improved accuracy and correct dosage delivery. But then that comes with an additional cost as well. What do we do when we run out of oral tablets and the patients are running with a HbA1c of 8 to 9%? And This is what the first add-on is always much, much better to add a basal insulin. And the way we start is any basal insulin could be added. You can add anywhere between 8 to 12 units of insulin as a rough measure, or you can go by the total body weight as 0.1 to 0.2 units per kg body weight, and then monitor your sugars. If you're just using a basal insulin, monitoring your fasting sugar would be more than sufficient, and I've given you the doses how to increase. Generally, any dose change will be anywhere around 2 to 4 units at a time. Wait for 3 to 4 days in a row before you make the second change. If there is hypoglycemia, then you need to cut back on your insulin. And this is the difference when I say analog insulins and conventional insulins. This is our NPH insulin. This is pictorial. Basically, our NPH insulin works around anywhere between 12 to 16 hours, but there is a conventional peak around the 4 to 6 hours mark, which causes a little bit of hypoglycemia at around 12 to 3 a.m. at night, whereas the newer analogs have glargine is almost has a comparatively milder peak when you compare to NPH, but the newer analogs are even better with reduced reduction of hypoglycemia. And this is what happens when you add a basal insulin. You get almost significant reduction in HbA1c over a period of 6 months. And then hypoglycemia is a big challenge when you use conventional insulin when you compare to the newer analog insulin. So this is from the Treat to Target trial, where there was about 800 patients of type 2 diabetes. So the analogs certainly work better, and the complications with analogs are much, much better. Right, basal insulin is one way to start, and it's very easy because generally you give basal insulin as a one-day therapy, and it's at the same time every day in the evening, whether it's 7 o'clock or 10 o'clock is your patient's choice, whatever is comfortable with him, with his lifestyle. What are the choices? Once you add basal insulin, you've got OHAs on top, and still you're not in target. So the options there becomes, in today's world, this is an opportunity to have a stopgap check with your patient whether they are following a good diet. Ideally, we would do that when we initiate the insulin, but here it's another stopgap check to whether they're following a good diet and lifestyle plan. And this is also another opportunity whether we would be able to use a GLP-1 receptor antagonist here so that it works in tandem with our drugs and injectables here. So I'll show you a couple of slides after that. The other option would be to move on to a pre-mix insulin. So how does this combination of basal insulin and a GLP-1 RA work? And there are lots of studies which shows that it controls both fasting and postprandial hyperglycemia. It has a significant impact on weight gain, where your conventional insulins will cause weight gain. When you combine a basal insulin with a GLP-1 RA, you've got significant advantages with possibly weight loss or at least even weight maintenance, and the incidence of hypoglycemia is almost negligible. So it is an advantageous combination in today's world, especially with the new potent GLP-1 RAs available. And thereby, once you combine these agents with your drugs, basal insulin, you're able to promote a more physiological insulin secretion and blood glucose management. It's almost like a basal bolus regime, but with the GLP-1 RA, which means, like in today's world, it's basal insulin plus once a week injection of your GLP-1 RA. So those are some evidences for that, but certainly it is very advantageous combining a GLP-1 RA with a basal insulin, if the patient obviously, if they can afford it. When do we just move on to the next level? So if, for example, if you've got the patient on basal insulin, you've tried the GLP-1 RA, it hasn't worked, then probably it's time to move on to your twice daily, whether it could be a premix insulin or a basal bolus. It's the patient's choice again, but we would certainly up the basal insulin up to a 0.5 units of body weight, and the HbA1c is not under control for at least 2 to 3 months, or the patient is suffering from hypoglycemia at night. So nocturnal hypoglycemia is something where you can't increase the basal insulin. After that, you need to think about prandial insulin. And this, where do we get this evidence from? This is from the 4T study, which was again a large type 2 study, showed that basal insulin is ideal to start off with. The patient gets a better experience, and adding, if targets are not achieved, then probably a mealtime insulin would be the next possible stop. And even a short-acting insulin at lunchtime would be a better option to start off with. So here comes the pre-mixed insulin, where we conventionally use our 30-70 mix or 25-75 mix. Most of the time we use it twice a day. The disadvantage of this is not so physiological because it doesn't work with all meals of the day, but there is some coverage of the lunchtime dosage because of the longer acting insulin during lunch. So there is marginal coverage with on top of drugs. It does most of the job. Generally, these patients have to be having a routine, fixed routine, so that the options are minimal with your pre-mixed insulin. If conventional insulin is used, then there is also an increased risk of nocturnal hypoglycemia, and often it's very difficult with the premixed insulin to drop down to less than 7 range, but most of the time we would like anywhere between 7 to 7.5 in most of our patients. This is one problem which we encounter with a premixed insulin. There was, in the middle, people were using a premixed insulin 3 times a day, where stacking happens, that your insulin tends to accumulate and cross-react with it. So this is broadly discouraged in most patients because this causes significant weight gain, increased risk of hypoglycemia as well. So having your premixed insulin 3 times a day is not advisable in the normal patient. This is commonly seen these days with our biryani culture, as Krishna says. This is, a lot of people don't think about their diet at all. They continue to eat whatever they do. They expect their medications to work irrespective of their calorie intake. And this is a common problem in the city with mostly young people. They'll say, I am on the perfect diet you have told me. And when you go in, they're consuming about 4,000, 5,000 calories a day, and they expect their insulin to work, which doesn't. So these patients go into a vicious cycle of eating, injecting, increasing their dosage, but still continue to have hyperglycemia. And this is a common problem. If you do not check on your calorie intake of your patients, these patients would be just frustrated and following a cycle of eating, injecting, weight gain, and continuing to increase their dosages. So be careful about this. And there are, once your premix also doesn't work, then the choices of your basal bolus regime is always an option. And then comes, if you look at the new EASD ADA guidelines, there is nowhere in here as insulin is out of picture, because we have got good drugs, good injectables, and only when the drug fails and still there is hyperglycemia, ADA or ACE advises you to start insulin. So whenever you start, we have gone through those things already. So to summarize, we have to individualize blood glucose targets for our patients, and we have to address insulin therapy or drugs from our patient's point of view, focus on their needs, values, and preferences. Newer insulin molecules offer improved tolerability, adherence, and safety issues. And all healthcare professionals will need to be aware when you're starting to prescribe newer insulins, both their advantages and disadvantages. Newer molecules like GLP-1RA can be effectively combined in our patients to get effective results. And patient education is also very, very imperative to facilitate all these things. Cost of insulin therapy has also to be kept in mind with the newer analogs, so that you have to address it appropriately. Thank you so much.